Welcome to this lecture on local anesthesia. This session focuses on a critical skill for the hernia surgeon, the use of local anesthesia. For many elective groin hernia repairs, it is the anesthetic of choice, offering significant benefits when used correctly. Local blocks can be utilized in health centers. We will begin by defining the goals of local anesthetic blockade for hernia surgery and then objectively evaluate its advantages and disadvantages. Crucially, we will cover the essential preparation and safety protocols that must be in place before you ever draw up the medication. The core of the talk will be a detailed, step-by-step guide to administration, showing you how to reliably block the key nerves. We will also address toxicity and complications, including how to calculate safe dosing and manage adverse reactions. Finally, we will review the assessment tools available to evaluate competency in this procedure. Let's begin by understanding what we aim to achieve with local anesthesia. The objective is a multi-layered blockade. We aim to achieve complete skin anesthesia along the planned incision line and in the subcutaneous tissues. Deeper, we need to block the sensory nerve supply to the musculature and aponeuroses. Finally, we must ensure anesthesia of the parietal peritoneum, which is crucial for managing discomfort when the hernia sac is manipulated. Local anesthesia offers profound benefits. It causes minimal physiological disturbance, making it ideal for patients with significant cardiac or respiratory comorbidities. It is also appropriate for use in health centers. Patients experience no postoperative sedation, allowing for a rapid recovery and discharge. The anesthesia provides postoperative analgesia for several hours. A key practical advantage is that it can be administered by the surgeon, streamlining the process. Furthermore, the addition of adrenaline constricts blood vessels, reducing surgical blood loss and prolonging the anesthetic effect, while also safely allowing a larger total dose. Local anesthesia is not a universal solution. It requires skill level and a gentle surgical technique, as rough dissection will cause pain. It provides a sensory block but does not fully block the deep, visceral pain from traction on the peritoneum, which can be uncomfortable. It is contraindicated in emergencies like a strangulated hernia. It is unsuitable for highly anxious patients and for repairing very large, complex hernias that require extensive dissection. Here is an illustration of the nerves that we need to block during the local anesthesia. Stop the video and note the ilioinguinal, iliohypogastric, and genitofemoral nerves. We can appreciate the innervation of the groin in this second illustration. These are the nerves that we need to target: ilioinguinal, iliohypogastric, and genitofemoral nerves. Preparation is paramount for safety. Explain the procedure to the patient so they know what to expect. You must know the patient's weight to calculate the maximum safe dose of local anesthetic. Intravenous access is mandatory in case you need to administer emergency medications. Furthermore, full respiratory equipment and a trained professional to monitor the patient's vital signs throughout the procedure must be present and ready. This is not a minor procedure. It requires the same safety standards as other anesthetic techniques. In a lidocaine block, the dose calculation must be done before the syringe is prepared. Note that the total dose limit increases when epinephrine is added. For lidocaine, the maximum dose is 5 mg per kilogram plain or 7 mg per kilogram with epinephrine. Remember, you must have monitoring and resuscitation equipment ready. Inject deliberately rather than quickly. Note that slow, divided injection and aspiration before injection reduce the risk of accidental intravascular injection, which is a major trigger of local anesthesia toxicity known as LAST. If the block is incomplete, stop and reassess rather than automatically giving a large extra dose. Treat early neurologic symptoms as warning signs. A patient who reports ringing in the ears or a metallic taste may be showing the first signs of LAST. Continuous observation matters because symptoms can evolve after injection. The emergency sequence for LAST in order is: stop further anesthesia, oxygenate, provide general support, and treat. Lipid emulsion should be given early for serious toxicity. Rapid response is the key to preventing progression to cardiac arrest. The usual management is the use of 0.5% lidocaine with epinephrine. 7 milligrams per kilogram divided by 5 milligrams per milliliter equals 1.4 milliliters per kilogram of 0.5% lidocaine with epinephrine. For the weight examples of 50 kilograms, the volume is 70 milliliters. For a 60 kilograms patient, it is 84 milliliters, and for 70 kilograms is 98 milliliters. The calculations are presented on the slide. Remember that these are maximum totals and that actual clinical dosing may need to be lower based on patient factors. Let's make the dosage calculation clear. A 1% solution contains 1 gram of drug per 100 milliliters, which is 10 milligrams per 1 milliliter. For a 70 kilograms patient using lidocaine with adrenaline, the maximum dose is 70 kilograms multiplied by 7 milligrams per kilogram, which equals 490 milligrams. This translates to 49 milliliters of a 1% solution. You can create a 1:200,000 adrenaline solution by adding 0.1 milliliters of adrenaline to 20 milliliters of local anesthetic. Always do this math before you start. Let's review the steps for inguinal hernia anesthetic block. Step 1 targets the ilioinguinal and iliohypogastric nerves. Locate the anterior superior iliac spine, or ASIS. Find a 0.2 centimeters medial and 2 centimeters superior to it. After raising a small skin wheel, advance the needle through the external oblique aponeurosis. You will feel a distinct pop or click. Then, inject 5 to 10 cubic centimeters of anesthetic in a fanwise pattern deep to this aponeurosis to bathe the nerves. Step 2 provides anesthesia at the pubic tubercle, a key medial landmark. After locating the tubercle and raising a wheel, again feel for the click as you pierce the aponeurosis. Inject 5 cubic centimeters of solution towards the umbilicus and another 5 cubic centimeters laterally along the line of the inguinal ligament. This blocks residual fibers and provides wider coverage. Step 3 is the infiltration of the planned incision line. Inject approximately 5 cubic centimeters of local anesthetic subcutaneously along the entire length where your skin incision will be made. This ensures complete skin anesthesia and provides a final layer of blockade. Supplemental local can be infiltrated after you make your incision. Remember, traction on the peritoneal sac can cause a vasovagal response with sudden bradycardia. If this happens, pause surgery and consider 4-atropine. Infiltrating more locally into the sac is necessary, so reserve enough local for that final step. Critically, you must know the maximum safe dose, 7 milligrams per kilogram with adrenaline, and not exceed it. Local inguinal block is an effective anesthetic technique for selected hernia cases. 0.5% lignocaine with epinephrine is as effective as more concentrated solutions. However, it is slower, so you must take your time. The low concentration means you should have adequate volume to provide supplemental infiltration as you make your incision, dissect the cord, and mobilize the sac. With practice, you can be confident that the procedure will be completed at acceptable levels of discomfort for the patient.